Lubin-Johnson.
Thank you, Dr. Sterling, and thank you again to Larry Ivory and the Illinois State Black Chamber of Commerce for having us all this afternoon. It's a pleasure to be here before you. And I'd also like to say I am glad to be on the same panel with someone who I call my longtime advocate in healthcare, and that's Senator David Kaler. We've known each other at least 15 years that I can think of off the top of my head. So once again, thank you. And I'm going to spend some time talking about opportunities and best practices within existing healthcare delivery paradigms. I'm going to segue a little bit into some of the thoughts that were already touched on by Marlo Kemp and also Dr. Sterling. And so with that, I'll begin. So, and I hope that you all will gain a better understanding of the need for theoretical and conceptual changes that's needed in some aspects of our healthcare delivery system in Illinois. And that includes the need for more small businesses to participate in the healthcare industry. And so I'm glad that we're giving exposure to small businesses today so that they can see some ways that they can become involved in the healthcare industry. Of course, I'm going to use a basis of this, the things that have gone on with this pandemic that we've been in for 18 months. As you know, our communities were devastated initially for multiple reasons, including access to care and the social determinants of health. And for those that don't know, these are the conditions in environments where people are born, where they live, where they learn, where they work, play, worship, and where they age that affect a wide ranges of health, functioning, and quality of life outcomes and risks. There were higher hospitalizations, deaths, and more illnesses in our communities, but there also, we had more issues with employment. We're the last hired and the first fired usually. Food insecurity. We have had, you've seen multiple setups for food drives through the pandemic, still going on today because we know we're not over this yet. But also housing. And housing has taken on two issues. One where there needed to be a moratorium established on evictions, but also initially the high rates of illness because people are living in congested housing situations, which have made it much easier for the virus to be transmitted. Also, we have transportation as an issue because more persons of color lack their own transportation, so they had to rely on public transportation, and of course, received, more increased risk of getting the virus because they were in situations with other members of the public. Learning, worship, and playing were also affected. Kids couldn't get outside and play as much, and they're already down anyway with video games and technology. Churches went virtual, and some churches couldn't go virtual. And so for many, that means they lost a source of support. And of course, learning, we know what has happened with our children having to go to virtual education. I mean, our children are already not learning or at grade level in at least, in the public school system here in Chicago. And so to go virtual has probably set them back. And so that's another one of those social determinants. Even without the pandemic, for a healthier population, we've really got to have programs that concentrate and focus on social determinants because we've got to figure out other ways to narrow gaps and inequities of healthcare. I saw, some comments in the chat about how much spending is done, for Medicare spending, how much is post-acute hospital care. And that's really because, as alluded to earlier, we are not doing the time being put in to preventive care. And if we prevent some issues from occurring, at this point, this is really where we have the greatest opportunity to do something about decreasing costs in this healthcare system. Decreasing payments or changing payments really isn't going to help. And I appreciate Senator Kaler saying we don't have a managed care system, we have a managed payment system. And Senator Kaler, I'm going to reference you every time I say that, but I am using that one from now You know, we had gaps already existing in illnesses that were a problem for those who got infected with COVID: asthma, diabetes, obesity. You know, if you had one of those illnesses on top of COVID, you had a much harder time recovering. And unfortunately, there were increased deaths before with that. And so these social determinants, you know, impact these already existing health inequities. And we know that these unjust and racist policies and inadequate distribution of resources lead to poor socioeconomic conditions that limit people's abilities to live healthy lives. Poor living conditions lead to health inequities also in the form of worse health outcomes, higher health costs, and greater disparities for those of color and in low income communities. Programs have been created before and during the pandemic to decrease these inequities that contribute to poor outcomes. University of Illinois had here in Chicago, their emergency room, they created a program to help people with housing. Blue Cross has opened the Blue Door Neighborhood Centers. They include fitness and wellness classes, but also assistance with social determinants of health. Sinai Health Institute has developed a program with community health workers, of which you're going to hear a lot more as we continue this conversation today. That program has led to a decrease in asthma visits in the ER by 73%, and also asthma hospitalizations by 75%. To achieve health equity, these socioeconomic and sociopolitical causes of poor health and health disparities must be addressed. The cost of inaction has emerged during this pandemic, exposing inequities that exist, demonstrating the crucial link between socioeconomic barriers and health outcomes. In order to address these issues in Illinois, there have been two major programs established to hopefully, and I say hopefully because I'm kind of skeptical, improve healthcare in the state. The first is the Healthcare Transformation Collaborative, of which there are multiple programs across the state, but there are three here in Chicago: South, West, and North Side. Looking in more detail, the South Side wants to have more providers. The North Side wants to have more access, better access to specialists. And the West Side has a more integrative approach on Medicaid and uninsured persons with behavioral health illnesses, adverse child experiences, hypertension, and diabetes. As was mentioned before, I was in private practice for nearly 30 years and caring for patients from 16 to 100, all incomes and all insurers, and yes, some not insured. And honestly, the West Side approach is the most holistic and includes Sinai, which I mentioned earlier, has a program that includes community health workers and positive outcomes. What they did was preventive care, decreasing trips to the ER and hospitalizations. Now, these three collaboratives have hospitals, federally qualified health centers, and other outpatient facilities. They do not include one Black business. There was a proposal submitted by two Black businesses, along with two Black not-for-profits, one of them being the local chapter of the National Medical Association, Cook County Physicians Association. The goal of this proposal was to increase programs for violence prevention, because that other not-for-profit does have one that does so, to facilitate community education via health fairs and other means of engagement. Unfortunately, it was not selected. This lack of inclusion may not bode well for the best results. The health care pillar was signed into law earlier this year. That's the second program. It includes over a dozen provisions to end inequities and expand access, we hope. One provision includes a commission to direct Medicaid contracts towards businesses owned and operated by those of color, women, and differently abled persons. Does anyone know of this commission? Has it met? Any African-American businesses get a contract? Any African-Americans on the commission? Don't know. Why is this important? The 2002 landmark study, Unequal Treatment, Racism in Medicine, concluded that African-American physicians provided better care to African-American patients. And in 2019, another study concluded that male patients in the Oakland, California area were more compliant with taking their cholesterol medicine, meaning they had a decreased risk of having a stroke or a heart attack, and also were more compliant with getting their influenza vaccinations. Knowing this, one would hope that the South and West Side programs would seek African-American businesses and organizations to help with the program's successes and grow businesses which would employ those in our communities. Not only do any programs achieve health equity and address the need for disparities that existed before the pandemic, but also we've got to address disparities that have been created during the pandemic. Just 2 weeks ago, a study was published in the Journal of the American Medical Association that concluded during the past 18 months, the diagnosis of cancer decreased nearly 30% from March to May of last year, and 10% from June to October of last year. That was mostly prostate cancer diagnosis, and probably that was mostly African-American men, and 20% from November of last year to March of this year. For those first two periods, there was a decrease in the diagnosis of 8 cancers: pancreatic, breast, colorectal, lung, prostate, cervical, gastric, and esophageal. We cannot buy our way out of this crisis. Prevention is key to decreasing disparities. Engaging patients outside of the doctor's office, emergency room, or hospital bed must be done. We cannot achieve health equity with the top-down approach, and those who need the care and those directly providing the care must be included. Thank you, and I look forward to questions at the end.